fortnight, just 2 weeks ago, we spoke about the basics of replantation, and mainly we concentrated on the indications and decision making. See, the first step in any replantation is the decision making. Once you have taken the decision, it is the process. It's more of a technical and an organizational aspect. We'll go into those details today. Just give me a moment, I'll share my screen. Yeah, so in the second part of replantation demystified, we would be talking about certain aspects. The anesthesia that is required, the steps of the actual steps of the procedure of replantation, then the dressings, the monitoring, the follow-up, how to deal with complications, and one important thing, management of failure. I remember seeing somewhere that the younger people are not taught how to handle failure. So they get very depressed or stressed, they call it now, stressed when they meet failure. We'll deal with that also, because that is, we have said that we have to try to replant every part, every single amputation as far as possible. And we have seen last 2 weeks ago, the last session, we have seen what are all the ways in which you can try to replant any amputated part. We may come across failure. We'll see how to handle that also. There is a wonder, why should we talk about anesthesia and replantation? It is very important. There was a time when we used to do replants under regional block. We used to give the block ourselves and do the replantation. But we faced a lot of problems in those situations because anesthesia and the anesthetist are most important for the procedure of replantation. So we'll talk about the need for the anesthetist, what is the role of the anesthetist. It's not just giving anesthesia for the patient. There are so many other things. Second is the significance of monitoring, because that is what the anesthetist is going to do. And thirdly, the monitoring parameters that we also should know about. The anesthetist is needed specifically in a patient with a replantation, more specifically in a patient with a major replant. We mean major replant when it's it's at the level of the arm, and a minor replant is the level of the finger. First, right from the beginning, resuscitation of the patient, the anesthetist does a wonderful job. They can exactly do the resuscitation and much better than what we can do. Second is good pain relief. Once the surgery begins, once you made the decision for replantation, good pain relief per-op and post-op can be given. Then monitoring the patient through the surgery and after the surgery, maintaining the hydration of the patient, and subsequent surgery. Supposing you do a replant today, you do the 6-hour surgery, and at the end, you find you send the patient to the ward and again find there is a problem, you need to get the patient back to the theater. So there again, the anesthetist plays a very important role. Now, monitoring is usually done throughout the surgery by the anesthetist. That is routine. That is done for any patient. They give anesthesia, they monitor the patient. Second is at the start of dissection on the stump. Then third is at the time of release of clamps. Once you have started the surgery, we go ahead with the surgery, do the anastomosis, and then at a particular point of time, we release the clamps. When we release the clamps, there is going to be multiple changes that should be taken care of, and that is handled very well by the anesthetist. And next important point is 10 minutes after the release of the clamp, there is another go along. All these are taken care of well by the anesthetist. I remember when I did my first replantation when I was in Stanley Hospital, we had a fantastic anesthesia team headed by Dr. Nagaswamy. And I started at 9 o'clock in the morning. It was an amputation at the level of the hand, distal forearm actually. It was a young girl. And I started at 9 o'clock in the morning and finished at 6:15 in the evening. There was no lunch break or anything in the middle or a coffee break or anything. And after I finished the surgery, they told me, my friends, colleagues told me, you're very lucky you had the anesthetist. The patient went in for cardiac arrest twice during the procedure and the patient was resuscitated. I did not know anything about this. I was concentrating on the surgery. That is when I realized that the anesthetist is so inseparable from a replantation surgery. You need to remember, if there is a sudden shock and there is a fall in the BP, it is very difficult to get the blood flowing across the anastomosis again, because all the vessels going for spasm, you cannot get the blood flow going as it was in a normal dynamic, hemodynamically stable patient. The tourniquet time must be monitored, the blood pressure is monitored, the urine output is monitored, and the pulse rate are also monitored. All these are done by the anesthetist. And we shall now go into the procedure as such. The amputated part has been brought into the theatre. The investigations have been done. It has been brought inside. The first step is bench dissection of the amputated segment, which we call as the amputate. So even before the patient comes in, or while the patient comes in and resuscitated and the anesthesia is being given, the bench dissection is being done. By that we mean that the amputated part is dissected and kept ready so that it can be fixed to the stump. Second is the dissection of the stump. Once the amputated part is ready and all the structures are tagged, we then dissect the stump. Then we need to do a fixation. By fixation, we mean fixing the bone together, repairing the extensor tendons, repairing the flexor tendons, doing the nerves, doing the vessels, all that. Then comes the important step of releasing the clamps. And lastly, skin closure. We'll see each of these steps in detail. Now, when you're talking about the bench dissection of the amputated segment or the amputate, the first thing is the skin incision. We need to make a correct skin incision because we need to access important structures, the veins, the arteries, the nerves, and of course the tendons and the bone. Now, if you look at the structure of the skin of the digit, we'll talk about the finger, the veins on the dorsum of the, when there is an amputation on the forearm or when there's an amputation of the hand, the veins are quite simple to get. But in the finger, it's slightly different. The incision that can be made on the amputate can be either mid-dorsal for the veins, mid-volar for the arteries, like this. The incision is made here, or mid-lateral. Whatever is done, either a mid-dorsal or a mid-lateral incision must be made and the skin raised. Till what position are we going to raise the skin flaps? The first thing we should remember is there are two ways of dissecting. The first structure that should be identified in the amputated part is the vein. The artery has got its own structure. It is quite stiff. It is easy to identify in the tissues, in the amputated pickup, because amputated part, it's quite easy to, of course, to identify the tendons. It is quite easy to identify the bone. And it's quite easy to identify the nerve also. But it is the vein that is the problem. That's the problem because it's become it's very thin and becomes collapsed. So what we need to identify is first, before we start mobilizing working on the amputated part, you can see the drop of blood still remaining in the veins. So that is a clue to identifying the veins. So to identify it, you can make an incision either subdermal. Here, supposing you make the incision in the subdermal, it goes like that. So you see that? It goes in that level. So when you make an incision at the subdermal level and raise the flap, now supposing you made a dorsal incision like this and raise the flap on both sides, you can see the fat under the skin. These are dermal flaps which have been raised. You can see the veins over here. So these can be made ready, dissected and made ready for anastomosis. There is another technique also. The incision can be made subfacial or these under the fat, subadipose incision. This incision goes like that. This is the extensor tendon on the dorsum of the finger. Over that you have got the fat and fascia in which you have the veins embedded. If you make the incision like this, just over the extensor tendon and raise the flap. This is what you'll see. So in this incision, when you make it subfacial, you're seeing the veins on the undersurface. You are accessing the veins from the undersurface. You can select which veins you want, dissect them out and bring them down. So this is the second type of incision. The first type of incision was the subdermal. The second type of incision is the subfacial. Now, we need to raise the thin skin flaps. On the volar side also, we can get the veins. That we will see when we are talking about the tip replants. On the volar side, you can get the veins which are more superficial than the arteries. We need to identify at least 2 veins for each finger. If it's a finger replant, we need to identify at least 2 veins. If it is a hand replant, we must have at least 3 to 4 veins ready, of which 2 must be major veins. That is, the cephalic vein is one major vein, and the second is on the ulnar side of the dorsum of the hand, you get another vein. These veins must be identified. Correlation exists between the number of veins repaired and the success. A general guideline is the cross-section of the veins repaired must be at least twice that of the artery that has been repaired. So this we need to identify. Sometimes we may find it difficult to identify the veins. At that situation, there is a tendency to say, okay, we'll do the artery first, the blood will flow in, and then the blood will come out through the veins, then we can see the veins. This is a common mistake that we all do. If you cannot identify the veins when there is no blood at all, it perhaps will be more difficult afterwards. There's going to be a lot of bleeding. There is another problem. When you allow the blood to flow into the artery and to come out of the vein and bleed outside, it starts the process of thrombosis. And when the process of thrombosis starts inside, if you do the anastomosis of that vein, you'll most probably end up in a thrombosed venous anastomosis. So we have identified the veins now. We made the skin incision on the amputated part. We identified the veins. On the dorsum of the finger, we can identify the veins for the middle phalanx and the proximal phalangeal region. For the terminal phalangeal region, you can identify it on the volar aspect of the finger, where it is much more superficial than the arteries. Next, we need to dissect, debride and tag the arteries. The arteries have got their own anatomical position. They can be easily identified and they have to be dissected and tagged. Then we have to dissect the extensor tendons, which can be found easily. Then we need to identify and dissect the flexor tendons. And lastly, we need to prepare the ends of the bone and shortening and prefixation. By prefixation, I mean, now this is the amputated segment that you are dissecting out now. Now what you can do is, we need to dissect the bone end. When we are dealing with the bone in the replantation, we need to remember when you're doing an arterial anastomosis or a venous anastomosis, it is best if these anastomoses are done without any tension. And definitely there is going to be some crush element. Even if it has been a clean cut, you're going to debride the 2 ends. So taking into account the elasticity of the vessel also, there is going to be some crush, some loss. So there will be some tension on the suture line of the artery or the vein. To overcome this problem, either you can do a vein graft or you can shorten the bone considerably. Shortening the bone considerably during doing the debridement will not compromise on the function. However, when you're doing a shortening, we need to decide which you're going to shorten. Whether you're going to shorten on the proximal end or whether you're going to shorten in the amputated segment. There is an advantage of shortening in the amputated segment because supposing the replant fails, you have not lost any length in the proximal stump. There are some situations, supposing there is a joint very close to the amputated part in the amputated segment. If you shorten distally, you lose the joint. In that situation, you will have to shorten proximally. So all the shortening should ideally be done distally, that is the amputated part. But if there is a joint just distal to the amputated level, it is better to shorten in the proximal level, proximal stump. Then you pass in a wire, you trim the bone ends, and then decide on what fixation you're going to do. There are different types of fixation. We'll see the different types of fixation. But the commonest, what we need to remember is we need to do as simple a fixation as possible, and it should be effective also. You should have a good bony union. Without a bony union, a replantation is going to be of no use because it may not function well. So a K wire is ideal, or a SS wire, stainless steel wire, can be used to do a good fixation. Some people apply plates and screws, but using plates and screws are going to strip the periosteum off, and that needs a little more expertise. So the best would be either stainless steel wires or K wire. Now the amputate dissection is over. It is now kept ready, and we keep it enclosed in a saline gauze and kept in a cup, sterile cup, waiting for the, or a kidney tray if it is a hand, waiting for the stump dissection to be over, when it can be brought in. Now, dissection of the stump. Same way, you need to make skin incisions and debride the wound. Here, again, debridement is very important. If debridement, sometimes when we are in the process of doing a replantation for the beginning stages, we are more worried about the vascular anastomosis. We do not give importance to the debridement. But please remember, if the debridement is not good, the results will be compromised. Even the success of the replant itself may be compromised because of infection. Next, we need to tag the veins, then the arteries. The veins can be found on the subcutaneous tissues, but it is the arteries that have the typical anatomical configuration which can be identified. Then we need to identify the tendons. At the level of the forearm, we need to identify all the flexor tendons. You can flag them or tag them, whatever you do, they must be identified. What we do is a very simple technique. All the flexors from superspeciality tendons we put together in a single suture of proline, tie it loosely, and just leave it aside with an artery forceps on it. So when you move all these away, what you have remaining is only the flexor profundus tendon and the flexor pollicis longus at the deeper level. So these can be repaired first. Then the flexor superficialis can be brought into the picture. Next is identifying the tendons, it's nerves. The nerves must be identified. Then again, preparation of the bone and shortening. We already talked about this. You try to prevent as far as possible shortening proximally. Do all the shortening on the distal segment as far as possible. Now, before we go into the fixation, getting everything ready, we need to get certain solutions ready. First is the irrigating solution. Heparin solution, 5000 units in 500 ml of normal saline. This is prepared, and usually it is kept in a cup with a 5 ml syringe. Why this specificity of 5 ml syringes? Sometimes, if the surgery takes quite a long time, the staff nurse may be changed. In that situation, it is very important that they identify, because you cannot identify by the color. All the solutions are colorless. So the staff nurse can identify that 5 ml syringe refers to the heparin solution. Xylocaine 1% solution, usually we prepare 30 ml of 2% xylocaine with 30 ml of distilled water, and we keep in a 2 ml syringe. So 2 ml syringe refers to, is for xylocaine solution. Lastly, normal saline, which we use for flushing, 10 ml syringe. Warm saline, we always get ready. We use after the anastomosis is over. That will not be kept along with the other instruments. Now, it is important to remember where we use an irrigating solution, where we use xylocaine. Xylocaine is used mainly to anesthetize the nerve endings around the vessel wall. So, this will prevent spasm. The next important point to remember is xylocaine is an irritant to the intima of the blood vessel. So, when the vessel is open, that is, before you have done an anastomosis, we should not use xylocaine. We should use only the irrigating solution, which is a heparin solution. Xylocaine 1% solution should be used only after the anastomosis has been done and the vessel ends are closed. So only in a closed situation we use xylocaine, and in the open, when the vessel is open, you can use heparin solution or even normal saline. Heparin is always better. Now, identifying the arteries. It's easier than veins because they have a typical, an anatomic configuration. And when you have an amputation of the finger, it is not that you're going to do anastomosis of both arteries. You need to do one artery, usually the dominant vessel. Usually the fingers, the ulnar side vessels are usually dominant, except on the ring finger and the index finger where the radial artery is dominant, radial side artery is dominant, and on the thumb, the ulnar side vessel is dominant. In bone fixation, now I told you we have already spoken about the use of K wires in bone fixation, or you can use stainless steel wires. There is something known as a box suture. That is, two K wires are passed both in the distal segment and in the proximal segment at right angles to each other. And once the amputated part is brought in here, you just have to tweak them together and tie the SS wires. The only problem with this is you will have knots on all sides. But this is a very quick fixation and a very rigid fixation. So we can radically debride the wound because the bone can be shortened. The inadequate bone shortening is the commonest mistake that is done in replantation surgery. Many times you can avoid the need of a vein graft, and nerves could be trimmed to good quality ends before repair. It is not the vessels alone, the artery and the vein alone that are important for a replantation. The nerves are also important. The immediate success of a replant surgery is survival of the part. The late success is the function of the part, and the function of the part can be achieved only if you have if you have done a good bone fixation, only if you have done a good nerve repair, only if you have done a good tendon repair. So all are important. Artery and vein for immediate success, the tendon, bone, and nerves for later success. Now, we have already seen last session, the red line sign and the ribbon sign when they are present. Now look at this ribbon. You can see the artery is tortuous. That means it has been pulled out. So these are not ideal for replantation. Second, when you are debriding the artery end, you are doing all this under tourniquet. After you have finished debriding the wound, you need to see the blood flow. So you must release the tourniquet and see the amount of blood flow from the artery. Usually it is said from the digital artery, the blood flow should reach the end of the table, and from the radial artery and ulnar artery, it should reach the end of the room. That is how usually it is described. So, and there are certain signs that you see which means that the vessel is not good. For instance, you can see this telescope sign. That is, the intima is herniating outside through the vessel. When the intima is herniating through the vessel lumen, it means that there is more amount of injury inside to the intima. You need to debride it further. Second, there may be a terminal thrombosis. In this situation, you need to cut till here. And lastly, it is called the cobweb sign. It is a very common sign. It looks very hazy, that lumen that you see. It looks very hazy when you look at it under the loop or under the microscope. You can see it's very hazy. It's called the cobweb sign. It is not good. When you want a successful replantation surgery, you need to remember that you should be completely happy with the lumen that you're getting from the artery. That is the basis, the first basis of all your success is that good artery, the good debridement that you've done on the proximal end of the artery. So, it is important to do a good debridement of the vessel. Do not worry if it is going to go very proximally. You can always put a vein graft. You want survival. You're going to do a great job doing a replantation. When you want survival, you can always do an extra anastomosis by putting in a vein graft. Or you can do what is known as transposition of arteries or veins from the neighboring fingers. You can put a vein graft like this, or you can transpose arteries from the neighboring fingers, or from the same finger, you can take it from the opposite side. So, I told you, you need to have a good arterial spurt. If this is there, your artery is good. So, you can go ahead very happily and do the anastomosis. So, the methods of fixation are all these, but all these are only theory. What you need to remember is that the K-wire is the best. There are some centers who even put plate and screw, especially on the forearm bones. You can do a plate and screw fixation. Some centers even put external fixators. Whatever it is, whatever you are quick to do, whatever is convenient with you, whatever you are comfortable with, it is better to do it. All you want to achieve is, remember, you want a good stable fixation. Second is you want a good bone healing. So then we go ahead with the repair. Now you brought the bone in, you brought the amputated part in, you have fixed it, and now you need to do the repair. What is the sequence of repair? Usually the extensor tendons are done first. 3O, 4O polypropylene can be used using horizontal mattress sutures. Why extensor tendons first? There is no particular reason. But after doing the extensor tendons, you come to the volar side, and because after doing the extensor tendons, you do the flexor tendons, then you do the veins again on the dorsal, then come back to the final side when you do the nerves and you do the arteries. So that just for ease of the logistics. Next is we do the flexor tendons. When you do the extensor tendons, there's another important thing is when you repair the flexor tendon, you can see the good cascade being achieved. So when you do the repair of the flexor tendons, we usually use 3-0 polypropylene core suture. This is for the hand and forearm because you've got different levels of replantation. We cannot generalize the suture metal that is used. Usually we use 3-0 polypropylene core suture with 5-0 polypropylene epitendinous sutures for flexor tendon repair in the fingers, hand, and in the forearm. Repair of nerves. 8-0 or 10-0 polyamide must be used. Under microscope, this repair must be done. It just takes a few minutes. Nerve repair can also be done after the vascular repair, but it is best done now when there is no bleeding, there is no blood obscuring the nerve. You can do an excellent nerve repair. Next is the anastomosis of the veins. There is a lot of controversy. You can do the veins or artery first, whatever it is, when you release the clamps, the entire circuit must be complete. That is, the artery and one vein or two veins, whatever, the circuit must be complete. So you can do the veins first or you can do the artery first, but do not release the clamps. So anastomosis of veins done with 9-0 or 10-0 polyamide, depending on the size, caliber of the vein. As you go distally, the caliber is not much lost, but it is the thickness of the vein that becomes much reduced in the distal portion, especially when you're doing a tip replant on the terminal phalangeal region. I told you there are volar veins, but they are very thin walled. You can identify them, you can see them, they are of good diameter. Okay, so now we have done, we are not going into the details of the vascular anastomosis. They are going to now release the clamps. Now this is an important step. Releasing the clamp. Why is it an important step? Because all this time, the amputated part has been in a state of ischemia. When the amputated part has been in a state of ischemia, we have already seen the cold ischemia time, warm ischemia time, and especially if there is muscle bulk in the amputated part, there are going to be a lot of accumulation of toxic metabolites. That is, in the amputated part, the cells go from aerobic metabolism to anaerobic metabolism. So the Krebs cycle starts. So the byproduct is lactic acid, and this lactic acid accumulates within the tissues. So when you release the clamps, this lactic acid and other toxic metabolites are brought into the circulation, which wasn't there earlier. So this can cause a sudden fall in the blood pressure, and patient may go in for a shock, especially when you're doing a level replantation at the level of the proximal forearm. This can happen very much. Then, when will we release the clamps? Before you release the clamps, there are two things you need to do. One, you need to get hemostasis. What is this question about hemostasis when the clamps have still not been released? There is no bleeding at all. But please remember, there are two things. One is the arteries and second is the veins. All these will start bleeding when you release the clamps. Remember, you're doing only one artery and a maximum of 3 to 4 veins. Can somebody mute? I think somebody is on. It is not muted. Galaxy on NXT. Could you please mute? Yeah. So now what happens is, you have done only one artery or a maximum 2 arteries and you've done a few veins. You have not done, there are so many more veins, there are so many more arteries. For instance, if you have done the ulnar artery repair or the radial artery repair, remember there is a posterior introverous artery, there is an anterior introverous artery. All these will start bleeding once you release the clamps. So we should be very careful and ligate all these or cauterize all these. Second, the veins. There are a lot of veins that have not been ligated. Once you release the clamps, all the veins will start flowing. The veins will also flow across the anastomosis, but the resistance there is more. The other veins will start bleeding. So we need to take care of those and clip them before we release the clamps. So just before releasing the clamps, there is a checklist that must be followed. One is general condition of the patient. Is he well hydrated? We need to make sure. Check the BP, pulse rate, urine output. If the pulse rate and urine output are not, excuse me, could somebody mute? I think some mics are on. I think they are not muted. Okay, so general state of hydration is very important. Is your Xylocane solution ready? Remember, I told you after the anastomosis has been done, we need to wash with Xylocane so that we take we anesthetize the nerve endings there to prevent spasm of the vessels. So Xylocane solution ready, Xylocane soap gauze ready to keep over it, because there may be a small leak which should also be taken care of. Warm saline pad should be kept ready over the anastomotic area. Most importantly is the anesthetist ready. Once all these are done, we can go ahead and release the clamps. Please follow this checklist to avoid problems. There are certain things, once you have released the clamps, you need to know in what order to release the clamps and what to do after releasing the clamps. So what is the sequence of release of clamps? First, the distal end of the vein, then the proximal end of the vein. Always from the distal, upstream, it's always released upstream. First the distal end of the vein, then the proximal end of the vein. If there is another vein anastomose, release that also in the same manner. Then the distal end of the artery, and lastly the proximal end of the artery, when the blood starts gushing into the distal artery. And it runs across the anastomosis, all the veins. After releasing the clamps, there are certain things you need to see. One, if there are these signs are seen, if these signs are measle sign, sausage sign, these are signs that the artery is not doing well. So, if, for instance, this is the proximal end and this is the distal end. When you release the clamp and this is what happens, this means that this is called the measle. Excuse me, somebody, could you please mute? Galaxy on NXT. Okay, measle sign and the sausage sign. So when these signs are seen, that means it is not good. Whenever you see something like this, immediately stop, go ahead, cut it till here, debride till here, and redo the anastomosis or put in a vein. Once you have done the vascular anastomosis, we need to monitor the anastomosis. First, how do you monitor this? You have done the anastomosis, you have released the clamps, and the blood is now flowing. You need to monitor now. Check the flow of blood across the anastomosis. There are different tests that can be done. You can do the milking test, but remember, never milk across the anastomosis. Milk only distal in the distal downstream from the anastomosis. Check the flow of blood across the that you can visually see that the blood is flowing. Second, color of the tip of the finger is very important. It must not be bright pink or blue or white. It must be a very light pink. Next is the warmth. Can warmth be felt with your gloved finger? Your finger is a glove. You can't feel warmth with a gloved finger. And bleeding from the tip of the finger, you look for the color of the bleed and the speed at which the bleeding is occurring. Now, while you're doing this monitoring, there are three critical times when you can, there are few critical times when you can have a problem. The first is immediate. Immediately you find there is no flow across the anastomosis. It means the technique of anastomosis has been poor. You need to redo it or relearn your technique. After 5 minutes, as soon as you release the clamps, it flows. But after 5 minutes, you find that there is no flow. The reason for this is poor debridement of the vessel ends, because a thrombosis has been initiated by the formation of what is known as a platelet plug. That is the first sign that it's going to get collapsed. So there will be a lesser flow. So after 5 minutes, immediately it flowed. But after 5 minutes, it came down. That means it is due to poor debridement of the vessel. I showed you the sausage sign and the measles sign. When this occurs, you need to chop off that end of the vessel, go proximally and redo the anastomosis. Now, it is flowing well. You said, okay, you're very happy. After 5 minutes also, it's flowing well. And then slowly you find at the end of 1 hour, by the time you finish all the other work, the hemostasis, the skin closure, you find that the vessel is not flowing now. It could be due to either a poor blood pressure head, or the patient has gone for a low blood pressure, maybe he had gone in for shock, or it could be due to the no reflow phenomenon, which could be due to the toxic metabolites that are built up, that is the superoxide radicals that are built up, that are causing the spasm of the blood vessels. There is no flow. It has flowed well, but for 3 days, it is going in for a due to poor post-operative hydration or a poor wound debridement, which has led to infection. Now, after doing this, you are happy with the anastomosis, you are happy with the tendon repair. Please remember, the tendon repair, the nerve repair should always be done as though it is being done for a primary tendon repair. For instance, if you had just a tendon repair, flexor zone 2 tendon repair, how we would concentrate on doing the tendon repair, that way the tendon repair must be done. So after doing all that, you need to close the skin. Now, as far as the skin closure is concerned, you must remember there should be no tight closure. If you are able to close primarily, good. If there is a gap, it is better not to close it tightly, because that will cause tightness or compression of the veins. The vessel is exposed. If you want to leave a gap, but the vessel is exposed, you can cover it immediately with a skin graft. A skin graft is not necessary to cover with a flap cover. Dressings, of course, you avoid tight dressings. Usually we apply bulky dressings. The tips of the fingers must be kept exposed and the thumb must be kept abducted in the dressings. What is the position of immobilization? We need to immobilize POP cast with elbow in 90-degree flexion, mid-prone position of the forearm, wrist in neutral position, MCP joint 60-degree flexion, IP joint straight. This is the position in which it is going to be kept. Wrist is usually kept in neutral position. You have done a repair of both the flexor tendons and the extensor tendons. Do we keep it in flexion or extension of the wrist? Neither. It is kept in neutral position. It is also a position in which the arteries are kept at relaxed position. This applying a POP cast with the elbow in flexion achieves immobilization, elevation of the hand, and when this sort of POP cast is put, patient cannot put his hand down. If the patient puts his hand down, it's going to compromise the blood supply. Now, this is the usual position we apply. You can make out that funnel, you allow the hand to be in a comfortable position. You can see all the fingers. You can even put in a ultrasound on the fingers. Post-op instructions are very important. You have done a great surgery, and after the surgery, you need to take care of the post-operative period. Very important. The patient must be received in the post-operative ward by the surgeon. This is very important. Patient may be put in a very wrong position, and this may cause problems. The position in which the patient should be nursed must be ensured and demonstrated to the ward nurse about the elevation of the hand. Details of the surgery and instructions must be given to the nurse by the surgeon, and monitoring must be done by a trained nurse or a surgeon or a team member. The patient must be kept on nil oral. The instructions usually must contain these 5 instructions. One is IV fluids. Usually for an adult, I give about 5 pints of fluids, which is a mixture of ringer lactate, normal saline, for 5 days. Whether the patient is taking orally or not, from the second day onwards, I insist on 5 pints of fluids every day. This is to maintain a hyperdynamic circulation. Second is antibiotics, analgesics. Third is anticoagulants. Now, there are different protocols. People have asked me what would be the best anticoagulant protocol. Anticoagulant protocol, it depends on what you are comfortable. I usually give at the time of release of clamps. I forgot to mention that. We sometimes give a bolus dose of 2,500 units of heparin bolus. I usually do it only in situations where I have expected some problem or there has been exploration. Otherwise, I do not give. Post-operatively, I give low molecular weight heparin, 0.2 ml subcutaneously once a day. So next is dressing change after 48 hours and monitoring should be done. Monitoring, by monitoring we mean general monitoring of the patient. For intraoperative monitoring we have seen, post-operative monitoring and late monitoring of healing. So general monitoring, consciousness level, pain relief. If the patient is continuing to have pain, there is a problem. I told you, if the patient has pain, there is going to be an increased adrenergic outflow, which is going to cause a spasm of the blood vessels. So it is best to give a good pain relief. Hydration, oxygenation, pulse rate, the blood pressure must be maintained. Urine output must be maintained. The hematocrit mainly must be maintained. Hematocrit must be measured. Usually 25 to 30 is important for adequate microcirculation. If it becomes more, there is more chance of clogging of the microanastomosis, of the microcirculation. So it's best to keep it dilute. And the blood sugar must also be monitored. Post-operative monitoring of the replanted part is also the same as the intraoperative monitoring. Only thing, you cannot have a visual assessment. But otherwise, the color of the finger, the turgor of the finger, so which can be, so the color, the capillary fill, the temperature, the turgor, and the dermal bleeding when you're not able to make out the warmth. Then there is a problem, what do you do? You have done a replant, you have finished the surgery, and you find that after 3 hours, there is a slight congestion. First, you need to know whether it's an arterial problem or a venous problem. If it is pale, if it is becoming paler, it's obviously an arterial problem. If it is becoming congested, it is a venous problem. Then you need to elevate the hand. If it is not elevated. Next is, we need to take up the patient for exploration. At the first sign of problem, all these things of elevation, removing all sutures, is only to bide the time. The plan should be exploration, taking the patient to the theater and looking visually, looking physically to look for the problems in the artery or the vein. You may need to do either an extravenous anastomosis, which may not be enough, or you need to redo the already done anastomosis, or you need to put in a vein graft. Now we'll consider special replants before we close. Multiple finger replants, tip replants, major replants, ring avulsion replants, trans-metacarpal replants. Now, when we talk about multiple finger replants, the commonest question is, should we do one digit at a time? Finish the digit, do the fixation, do the tendon repair, do the artery, do the vein for one digit, then go to the next digit? Or should we fix all the bones first of all the fingers, then do all the extensor repair, then do all the flexor repairs? So the first is called the digit by digit method. The second is the structure by structure method. Usually, as far as the fingers are concerned, time is not a constraint because the amount of muscle present in the finger is quite less. So it can withstand ischemia for a longer period of time. So usually time is not the constraint unless the patient has presented very late. If time is an advantage, tissue by tissue method is ideal. You first do the fixations, then you do the tendon repairs, then you do all the veins, then you do all the arteries. If time is not advantageous, you can do the digit by digit method. But the advantage of this is you don't have much time. So what you can do is you can prioritize the fingers. You can do the thumb first because that is very important, and make sure the thumb is viable. Then go to the index finger, or then go to the mid finger. So that way you can do it. You can prioritize your fingers. But remember, when you do the digit by digit method, there is a small problem in that you may compromise the vascularity of one particular finger when you manipulate the next finger. So you can do the digit by digit method if you've got a lot of time. Otherwise, you can do the structure by structure method, which is, I'm sorry, if the time is it's an advantage for you, you can do the tissue by tissue method or structure by structure method. If time is not advantageous, you can do the finger by finger method. So this is an example of multiple finger replant. The thumb, the index and mid have been replanted. These two have survived. Now we'll come to the fingertip amputations. Now this is the Tamai classification, Susumu Tamai classification. It was very simple. Zone 1 distal to lunula. Zone 2 is distal interphalangeal joint up to the lunula. That is the nail fold. However, more detailed classification, like the Hirase classification, where it was based upon the artery, the configuration of the artery. Where in zone 1, it was distal to the digital artery termination. In zone 2, it is of two types, zone 2A. So the vessel ends over here, so this is zone 1. There's no artery at all. In zone 2A, distal to the terminal division of central artery, and zone 2B is nail fold to the distal terminal branches. Zone 3 is DIP to the nail fold. This is zone 3. So you can get the veins also here. This is the Allen classification. In zone 1, it is almost like the Hirase classification. In zone 1, there is no bone fragment and there is no vessel also for anastomosis in children. In children, it can be just put back as a composite graft. You cannot do a replantation at that level. In zone 2, the amputation goes through the nail bed, preserving at least one half of the nail bed and sterile matrix. There is no dorsal vein available at this level. Venous drainage is achieved by repair of palmar vein or by controlled bleeding. We'll see what is this controlled bleeding. Controlled bleeding means when you don't have veins, you can use leeches or you can use other techniques by putting in an IV cannula. In zone 3, it is similar to zone 2, but because the remaining nail bed is shorter, a hook nail deformity is likely to occur if the replant fails. And in zone 4, it is proximal to the nail fold. Dorsal vein usually can be dissected and repaired. Here you can do the repair of the dorsal vein. So the sequence in tip replants is slightly different from what we saw in the other replants. Here it's the identification of veins, identification of arteries, skeletal stabilization. Artery repair first in zone 2, especially if you're able to find the artery. Vein repair first in the other zone 2. And nerve repair to be done in zone 2, not in zone 1. And skin closure. And skeletal stabilization, there is something known as a no hardware technique in zone 1. And a single axial K-wire in zone 2 and primary arthrodesis can be done. So here, this was described from Ganga Hospital, where you do a primary repair of the nail bed. Now this is the amputation at this level. You can repair the nail bed. That will sort of splint the terminal phalanx together. So you don't need to put in a wire. As I told you, the veins are very superficial. You can do the artery anastomosis first, then do the vein anastomosis. When we can't find veins in tip replants, what do we do? The distal artery you can see, you can put the distal artery to the proximal vein, or you can use medicinal leeches, or you can make a transverse tip incision and allow it to bleed for a few days till there is a collateral circulation developing. Next is re-exploring the next day. So you look for veins now. By this time, a good amount of circulation has developed and the veins become a little more robust. It may be possible to visualize the veins on the next day. Subdermal pocket procedure so that the veins drain into the, budding it into the abdomen. Intravenous cannula can also be applied. Next, we come to major replants. In the major replants, especially the arm level, the time factor is most important. We know that the forearm has a lot of muscle. which can lead to a lot of problems. So the amount of necrosis that occurs, if it goes beyond the time, because muscles cannot withstand ischemia well, they may go in for irreversible changes. So heparinized saline infusion can be done. The sequence of surgery again is changed here. The arteries and veins are done first, and then the bone fixation, and then the muscle repair is done, and the nerves are repaired. Because this is obviously because you want to cut down the time of ischemia. And important to remember here is you must do a fasciotomy in the distal part before you allow the vessel, the blood to flow into it, so that you prevent a Folkman's contracture leading to another problem in the distal part. Sometimes you can just start a solution. This is usually kept, heparinized blood is given, or a heparinized ringer lactate can be given, but you must hold it at a pressure because it will normally not flow. You need to hold it at 100 centimeters above the level of the hand, so that the pressure is mimicked. The blood pressure of the heart is mimicked. So the solutions that can be used, different solutions, papaverine or low molecular weight dextran with heparin can be used, or the soy solution, which consists of injectable lactated ringers, heparin, and preservative-free lidocaine. Usually heparinized lactated ringers is usually used, which is quite easy to use, and it can be kept refrigerated so that it can reduce the metabolic demands of the distal muscle and the part. Next we come to avulsion replants. When we say avulsion, obviously we have seen what the avulsion entails. It entails avulsion of the skin. So we need to remember that as to differentiate it from other replants, you may need skin cover later, either in the form of a skin graft or a flap. Second, there will be avulsion of the vessels. So we must remember, either you debride proximally and distally and identify good arteries and do a vein graft, or you can do a transposition of a vessel, of an artery from a neighboring finger or the same finger, as we have seen. Supposing there is a ring avulsion amputation of the ring finger, which is just very commonly seen, one artery from one side, it usually will be long. That can be transposed to the other side distal segment, so that you can avoid a venous graft. Then avulsion of nerves. So you may need to do a secondary reconstruction there. There may also be a bone loss. For this, all you need is skeletal stabilization. If necessary, if the amount of bone loss is compromising the function, you need to do a reconstruction of the bone later. Ring avulsion. Now this is an example of a ring avulsion. As I told you, on one side, the artery was long. It is always, avulsion is never like this. It is in one side. So what happens on one side, the artery is short, other side artery is long. So use the side where the artery is long, debride it, just cross it over to the other side where the distal artery will be long, and we can do the anastomosis. So this is the result, where we did a cross arterial anastomosis. Here in this total avulsion amputation, I think I showed you this example last week also, where we have transposed the finger, we have transposed the artery from the index finger. We transpose the artery from the index finger to the thumb. Lastly, we see the trans-metacarpal amputation. We have a classification known as the LODA classification. Now the problem in these is, there are two types. There are two zones in trans-metacarpal at the level of the palm. One is zone A, where it is proximal to the superficial palmar arch. Zone B is distal to the superficial palmar arch. You can imagine what the problem is. If it is at this level, zone A, this is the example to show the zone A amputations are proximal to the superficial palmar arch. In zone A amputation, it's possible to revascularize the entire digit by repair of single artery. You just do the radial side artery or the ulnar side artery, you can get the whole hand revascularized. But in zone B amputations, you may need to repair multiple common digital vessels, and especially if there's been a crush element, it is ideal to take a vein graft from the dorsum of the foot, which has got multiple tributaries, and anastomose it to the different vessels. So, after doing a replant, I told you the final success is in the function that is going to be achieved. There are different criteria for measuring this function. The Chen's criteria is very common. Chen's criteria of functional evaluation, grade 1 is excellent. Patient is able to get back to his own work, the original work that he was doing, and with the contribution from the reattached parts, the range of motion, active range of motion is more than 60%. There is a normal sensation and grip strength is 4 to 5 out of 5. Grade 2 is good. Patient is able to resume some gainful work but not the original work. So that means there is some decrease in the function of that hand. The active range of motion is 40 to 60%. There is satisfactory sensation, grip is 3 to 4. Grade 3 is just fair return, independence in activities. He's able to do his own work, but he's still not been able to go to work. The active range of motion is 30 to 40%. There is only protective sensation, no fine sensation is present, and grip strength is poor. And lastly, tissue has survived, but there is no function. So this is the poorest. So though the tissue has survived, there has been no function at all. Management of failure. This is the last. Handling failure. There are 4 things you need to handle when you have had a replantation and you have had a failure. First, you have to handle the patient. He's the most important part of our entire of our work. He must be handled first. Then you handle the wound. If it is failed, you need to take it off. When you take it off, there is a wound there. That has to be handled. Then you have to handle your team members. And lastly, you have to handle yourself. Handling the patient. You need to talk to the patient attenders. It is difficult. It is difficult to tell them that it has failed, but you need to talk to them. But when you talk to them, please remember, don't talk to them in an apologetic tone, as if it has been your fault. Never. You have done the work. It has just not succeeded. That there are so many factors that would have gone into it. Do not talk in a tone as if you don't care. That is also not right. We need to talk with empathy. We understand that he is going through a problem. We understand that he has got a failure, but we will do something for them. The acceptance of the failure on the part of the surgeon will usually go down well with the patient if you deal with it in a calm and empathetic manner. Then we need to discuss with them the further course of action, the need for another corrective surgery, the need for a longer stay, and the need for additional expense. Handling the wound. You need to remove the gangrenous part. Then after that, you need to reconstruct. If it is the finger, you must consider the residual length. If there is a good amount of length, you can do a flap cover. If there is a good amount of length, you can do a shortening closure. If the bone length is quite good, you are not able to close it primarily, you should not shorten, give a flap cover to retain whatever length is there. And after that, you need to plan for a prosthesis. If it is the thumb, you need to give a flap cover and do an osteoplastic reconstruction or a toe transfer. If it is the hand, you need to provide a good sensate stump and plan for prosthesis. Handling your team members. They have also been with you during your procedure of the replantation. Everyone has been contributing and everyone is involved. So they also must be told about the result and discuss with them why it probably went wrong. And yourself, you need to handle the stress of resurgery, concentrate on the things to be done next, and go ahead. Handling the stress of convincing the patient attenders. It is stressful, you need to talk to them. And most importantly, analyze the cause of failure. This must be done not like a fault finding. You're not sitting there to find fault, but to avoid failure later in the future. Because if you fail, you have not lost anything. You have gained a lesson. You have learned something that can be put to use in the next surgery. Most importantly, do not blame others for failure that occurs. We sometimes say patient kept his hand down. The patient did not take his tablets properly. The staff nurse did not give the injections properly. That may be there. But as the leader of the team, as the surgeon, you should take the blame upon yourself and take the team forward. Thank you. I think there are some questions. Hello? Yes? No volume. Nobody heard anything. Hello? Anybody there? There is a question from GB Rajan. Should the vein grafts be in the same original plane or superficial to the flexor tendons? I don't know. I've always put them in the same plane. Okay, thank you. I've always put them in the same plane. What do you feel, Rajan? Do you think that they should be put in a different plane? The only thing I avoid is I avoid putting a vein graft under the artery because the artery can compress. Otherwise, I put them in the same plane.
Sir, we did one hand replant.
Okay.
And we did shortening. We did a free flap also for ALT also.
Okay.
And it survived well.
Okay.
I discharged the patient.
Okay.
He came for one review. Second review, when he came, I saw it was dark. And he apparently thought that it was the color of the betadine that is giving him.
Yeah.
So it was painless for him.
Okay.
And the cost had already gone because almost 13 hours.
Okay.
So when then we had to immediately take him. I said it's gone, but let me see. I saw the arterial vein graft. Sorry, the vein graft for the artery was thrombosed. And I thought probably if I put the vein graft superficial to the tendons, I would have saved, because now it is caught between the bone and the tendons. Now I didn't know how to explain. No infection.
Correct.
No, and only the thrombosis I see, nothing else.
Okay. Yeah, I think I have had this problem also. That is why I told you I avoid putting my vein graft under the artery. That's the only thing I've noted. And when the tendons are there, I usually try to put them superficial to the tendons. I think your question, that's where your question comes in. Whether it should be superficial to the flexor tendons. Because the vein grafts, because they're using subcutaneous veins, mainly subcutaneous veins, when you're doing the vein, I have never put vein grafts for the vena commitants. I have done vein graft for the subcutaneous veins. And when you're putting vein graft for the subcutaneous veins, there's no issue. You're going subcutaneous, you're superficial to the flexor tendons. I think you're meaning when you're putting vein grafts for the vena commitants, you have a problem. The problem you're talking about.
Sir, actually, this particular case, which we did, the artery on one side had to be connected to the artery, that is the ulnar artery distally.
Okay, now I understood.
Because it is now crossing the diagonally.
Correct.
And now the choice was to put under the flexor tendons or above. Yeah. We took this chance and put it in the same plane below the tendon.
Okay.
And we got caught that way.
Yeah, correct. I think that way, now that you've clearly explained it, I think we need to go superficial to the tendons.
So it is very costly for us.
Yeah,
to put it underneath the tendon and then see.
Yes,
and especially if it an infection, I would have been satisfied telling, yeah, it was the infection that lost.
Yeah,
but
correct. This is
it's a technical thing that we.
As I said, we keep learning with every. You think it's always tending towards zero. You're learning about replantation. You learn 2 new points today. You think you have finished everything. You go to the next case. You learn another 2 new points.
The second doubt is in tip replants.
Yeah.
The most common tip replants that we see is door hinge injuries.
Yeah.
In pediatric.
Yeah, correct.
And even adults. Usually it's the grandmother or the grandchild.
Yeah.
So when it's crushed and it's contused, what do we tell? Should you still go and try, or we say not possible? The second second situation is usually the motorcycle spoke injuries.
Yeah, correct. Yeah. Now, as far as door crush is concerned, if it is at the tip of the finger, usually in children, I put it as a composite graft because the amount of crush element is more on both sides, especially the distal portion, isn't it? So there, if you debride it, you are left with nothing. You go into zone 1, that's all. You won't have anything over there. There's no bone there. And there is no point in doing it. If it has been little more proximal at the level of the lunula, we can attempt a replant when you debride on both sides. But this motor pump or motor cycle injury, that is typically, it is associated with some heat element also. You have some amount of charring of the tissues. Usually I don't do a replant. The replants that I've done for the tip are mainly for cut, slice, what do you call it, a guillotine amputation. Crush amputation, usually I have not seen proximal to the nail fold, in which case you can do a replant.
So in door hinge tip injuries, if the pulp is contused, we can see that it is like as though it is, what do you do?
There's no point, you cannot do it. It's the vessels inside are injured. Correct. It's crushed and the vessels, like how we were talking about the ribbon sign, remember? Right. The ribbon sign, you have that, the red line. You have the red line. That means the vessel is ruptured over there and it is bled under the skin. When it is blue over there, it means all the veins that are superficial have bled under the skin. So when that amount of ecchymosis is there on the pulp skin, it usually cannot be replanted.
Because the decision has to be made in the EMR, not in the theatre, whether can we do it or not.
Yes, you need to, we can safely say that when there is a bruising there, you cannot do it. But they always, when it's a child involved, they are always, the emotional factor is more. So then what I do is I thin it and put it back as a full thickness graft or a composite graft. That takes to a certain extent. I have seen composite grafts take well even in adults. That is at the level of the middle of the nail plate. Distal to that, the composite grafts take quite well, quite acceptable. It's better than doing any other reconstruction.
Thank you, sir.
Thank you, Rajan. Okay, if there are no more questions. Okay, shall we close, sir?
Yeah, thanks once again.
Thank you.
We'll see you next week, sir. Thanks for it.
Thank you, sir. Thanks.
Thank you.